our Sudanese Surgical Club and addressing a very important area of early breast cancer. Of course, in Africa, we used to have the advanced breast cancer, but we hope, with probably some education and screening, we get early breast cancer. So the floor is yours, Dr. Jerry. You are welcome.
Thank you, sir. Thank you very much. I can start now, sir.
Yes, sir. Now you can start.
Hi, welcome to everyone. Today I'm going to discuss about the management of early breast cancer. As Professor has discussed, it's very rare to get the early stage breast cancers in African countries, but still we need, whenever it comes to our OPDs or our presentations, we should know what best we can provide to our patients when they present luckily in early stages. It's a small lecture as an introductory first class to me. So I'll try to make it short and sweet. Okay. So the early breast cancer is divided mainly into two parts. One presentation is the non-invasive and another is invasive breast cancer. When we discuss about non-invasive breast cancer, it is further divided into two categories. One is lobular carcinoma in situ that also have a variable presentation. It may be in the classical form or it may have some differentiation called as pleomorphic lobular carcinoma in situ. Another that is more common, which is called ductal carcinoma in situ. So first we'll discuss about the lobular carcinoma, which is rare, but which is more benign. When it presents as a classical form, which is concordant with imaging, as well as needs only follow-up and risk reduction counseling, because in the updated guidelines, lobular carcinoma in situ actually is not cancer, comes under the benign category. Pleomorphic lobular carcinoma in situ is different from the regular carcinomas, but it needs a surgical excisions to see any invasive component to confirm to diagnose definitive diagnosis whether it is actually pure lobular carcinoma in situ or some invasive component is there. If it is pure lobular carcinoma in situ is confirmed, we don't need to do anything for that. We can keep the patient on observation. And if we found it is not only lobular component, but the ductal carcinoma component is also there, then in ductal carcinoma component, we have to follow the guidelines separately as routine invasive guidelines. Now come to ductal carcinoma in situ. Ductal carcinoma has very high risk for the invasive component, although it is not developed into the cancer still, but if it comes as a presentation of mass or some other thing, that it may have some hidden invasive component. So in case of ductal carcinoma in situ, we should go for MRI if no mass is palpable or if there is nothing visible on the mammography. It's very common to see the lobular carcinoma not visible on mammography, but ductal carcinoma in situ also may be some small lesion which is not visible on mammography, but they may have some suspicious areas like microcalcifications or some architectural distortions without any palpable mass. In that case, we should go for MRI to define the lesion. If it is proved as a ductal carcinoma in situ alone, then ductal carcinoma in situ doesn't have tendency to spread to the axillary lymph nodes, and lumpectomy is sufficient treatment for that. If we found any microinvasion or any suspicious component for invasion, then lumpectomy should be tackled along with some lymph node management also. It can be a central lymph node biopsy or it can go for the lymph node dissection as well. It depends on whether the lymph nodes are palpable or not, or whether we can localize the lymph nodes. For all cases with lumpectomy, it needs the radiotherapy. If we are not removing the whole breast and we are removing the tumor alone, then definitely radiotherapy is mandatory in all cases. Either it is the invasive component or either it is only ductal carcinoma in situ. Total mastectomy is a contraindication for in case of we cannot give the radiotherapy. In some cases, patients have their individual contraindications for the radiotherapy, or they don't want to they want to avoid the radiotherapy. In such case, we should prefer for the total mastectomy without any axillary dissection. If central lymph node biopsy is not feasible, either technical complications or some other issues, patient related issues are there, in that case we have to go for axillary sampling. That includes the central part of the level 1 lymph nodes, we remove 4-5 lymph nodes. This is called axillary sampling, or the conventional axillary dissection. So now question is, can we avoid axillary dissections for suspicious invasive component? We have seen the ductal carcinoma in situ, and we have high suspicions whether it is a big mass, and it may have invasive component as well. In that case, can we avoid the axillary dissection? Yes. If central lymph node biopsy is not available, in that case also we can avoid axillary dissections when we can do lumpectomy and we send the sample for the frozen section. It shows whether it has an invasive component or not. If there is no invasive component, we don't need to do any axillary dissection. If it comes positive for the invasive component, we directly go for axillary dissection. So when the central lymph node biopsy facilities are not available, in that case also we can avoid central axillary dissections by the frozen section of DCIS. If it is negative, then straightforward lumpectomy is sufficient, and then we will follow with the radiotherapy. After removing the DCIS, we have done the lumpectomy, and in final histopathology, it comes as a invasive carcinoma. Then what we should do? We have to see the marginal status, whether we have removed the whole tumor or if the margins are positive for the malignancy. If the margins are negative, there is no remaining tumor, then axillary dissections alone is to be done. Because in that case, now the lump has already out, we cannot do sentinel lymph node biopsy in absence of breast lump. If the margins are positive, then axillary dissection alone is not sufficient. We have to go the re-resections. We have to refresh the all margins with axillary dissections. And again, if the resected margins are also positive, when we do the resection, re-resection of the margins, we have to send it for the frozen again. And the frozen comes again positive, then we have to go for total mastectomy. It shows that DCIS is spread in the whole breast, which is not as a palpable mass, but it is a microscopic DCIS, which is in the whole breast, and we have to go for total mastectomy. How we follow the patient with DCIS? We have to consider the hormone status for all DCIS patient also, so that we can do the risk reduction therapy. Risk reduction therapy is the hormone therapy for the next 5 years in DCIS patients also, if they are ERPR positive. Indications when we are doing the breast conservative surgery for DCIS, with or without radiation. We have to do clinical examinations in every 6 months for at least 2 to 3 years, and then yearly checkup. And mammography in every 12 months, means once in a year, when we have done the breast conservation in DCIS. Now we have discussed the DCIS. We'll come to the invasive carcinoma now. Invasive carcinoma, when present to us in the early stages, we have to define the stage for the nodal status also, for the metastasis also. So this is the AGCC classifications, where we can see that up to 2 centimeter tumor is a T1 and 2 to 5 centimeter is T2. This is very important to decide whether we can go for the breast conservation surgery or we have to do the total mastectomy. T4 lesions involves the chest wall also. It can be a chest wall, it can be a 4D involving skin, it can be both, and 4D is inflammatory carcinoma. Regional node, very simple. It's the N1 when we are lateral to the axillary fold, that's level 1 and level 2. If it is mated, then it goes to N2A. If it goes to internal mammary nodes alone, then it is N2B. If it is N3, means infraclavicular or the level 3 axillary lymph nodes are infraclavicular, clinically palpable, it is N3A. If it is internal mammary lymph node with axillary lymph node is N3B. And if it is supraclavicular lymph node palpable, previously it was considered as the metastasis. Now it is also in the regional lymph nodes, that is N3C. These are all advanced carcinoma. Then we have to decide what exactly comes in category of early breast cancer. This is also to discuss with especially for the residents of surgery. Then when we should not confuse with the skin involvement definition. When we see in the clinical examinations, is there any skin tethering or the nipple eczema or the dermis involvement or any nipple retraction or the skin retraction? It is never considered as a skin involvement. Skin involvement is considered only when the ulcer is there, when satellite nodules, which is macroscopically visible, or any tissue edema like pedo orange appearance. This is the skin involvement in breast staging. So what is the early breast cancer? Early breast cancers we consider is the T1 or T2, means less than 5 centimeter tumors with N0 status or level 1 or level 2 axillary lymph nodes just palpable. Sometime previously all the operable cancers were considered as early breast cancers, but now the target of the treatment has changed. We want to preserve the breast. We don't want to do the mutilating removal of the whole breast. In that case, we have to manage the early breast cancers only in up to T2 stage with N1 maybe, but mainly up to T2 and 0. Lump of 5 centimeter or more or any fixed nodes are advanced cancer. So what is the aim of the treatment in early breast cancers? First, to achieve the complete possible cure. In that, we have to control first the local control by the surgical management. The target in the local control is not only the cure, but also we have to see the psychological aspects of the patients. In that, the form of the breast and functions has to be maintained. For that, the target should be the breast conservation. Then we have to prevent the local recurrence by the systemic therapy, and we have to prevent the distant metastasis again by the systemic therapy and the radiotherapy. So what we workup will do for the before the starting any treatment in stage 1 or 2, that is called the early breast cancers, without any significant involvement of the lymph nodes. So the bilateral mammography is mandatory in all early breast cancers to see whether we can preserve the breast or not. Because one lesion can be palpable, there may be some small lesions or some tissue level structures changes like microcalcifications in some other quadrant of the breast. If the breast has multiple locations of the any mammographic changes like microscopic calcifications or any small lump which is not palpable, so which rules out or which gives our options of breast conservation out. In such cases, we cannot go for the breast conservation. That's why mammography is recommended in all breast cancers, all early breast cancers, or if the patient is less than 35 years or they have a very dense tissue, dense breast consistency. In that case, mammography is a very coarse very I can say that it's a very difficult investigations in them, because in that it is very rude. In such cases, we should go for the ultrasound. That gives a better architectural definitions in the ultrasound rather than mammography. Mammography is images doesn't give good pictures of the dense breast. Then we should go for the core-needle biopsy. If we can hold the mass, if we can palpate the mass easily, then core-needle biopsy is the best. In a very small tumors, less than 2 centimeters, that we difficult to hold for the biopsy, we can choose for the FNAC. But preferably, always core-needle biopsy should be done. Liver function test and chest X-ray for the early breast cancers enough. Metastatic workup, extensive metastatic workup is not required in asymptomatic cases. If the patients are symptomatic for any systematic symptoms, then we can go for the liver function test, bone scan if they have any bone pain or if any raised alkaline phosphatase in liver function test, CT scan abdomen or CT scan chest if they are symptomatic. And we are talking here only about the early breast cancers. If the patient has a big mass of 5 centimeter or more, or if they have any lymph node dissemination palpable clinically, then the extensive metastatic workup is always required. Whole body PET CT scan don't recommended in the early breast cancers, in the very early breast cancer, but it can be done if it is available or if it is a large tumor. That totally depends on subject of availability. So now we'll come back to the surgical management, because early breast cancers directly we should choose for the surgical management first, with the target of breast conservation surgery, which includes the lumpectomy with the adequate margins all around with the axillary staging. Axillary staging we can do with the central lymph node biopsy or the axillary dissections. It is best, the breast conservation surgery is best for very starting stage like the T1, N0, M0, or if the T2 or T3 lesion, T2 lesion also we choose for the breast conservation directly, which is fulfill the all other parameters of breast conservations. The most important one is the breast mass with the tumor ratio. If the patient has a big breast with a small tumor, even in the T2 or T3 lesion, in the size in relation to the rest of the normal breast tissue, we can go for the breast conservation. And if the tumor is quite big in ratio to the breast size, then we should prefer to go for the neoadjuvant chemotherapy or the hormonal therapy, depending on the other risk factors, so that we can downstage the tumor, we can reduce the size, and then we will go for again with the target of breast conservation. If there is any contraindication for the breast conservation surgery, then only we should prefer to go for the modified radical mastectomy. I hope People knows what are the contraindications for the breast conservations. Just like the main is the very big tumor in a very small breast, or any contraindication for the radiotherapy like the connective tissue disorders or the pregnancy, or unavailability of the radiotherapy centers, poor compliance, inability to go for radiotherapy. Mainly the contraindication for radiotherapy is contraindication for the breast conservative surgery also. Then with the breast management, we'll go for lymph node management. If the lymph nodes are not palpable clinically, we should not directly jump over the axillary dissections. Axillary dissection is must when the palpable lymph nodes are there, but non-palpable lymph nodes should be managed with the sentinel lymph node biopsy. If the palpable node, sometimes what happens, we cannot palpate the lymph nodes in the obese patients, but they are present radiologically. They are there in the ultrasounds or they are in the PET scan. They are lightened up. In that case, we should go for the FNAC for the axillary lymph node, not for the breast mass. It is for the axillary lymph node, and if they are negative, they can be kept for the observation, or excisional biopsy can be done for the lymph node also. When should we go for the sentinel lymph node dissection? Early breast cancers, as we discussed, T1, T2 with clinically non-palpable negative nodes. Palpable nodes are always for the axillary dissection. If the non-palpable clinically and the small primary tumor, we should do sentinel lymph node biopsy. Or any DCIS where we are going for the planned mastectomy. As we have discussed previously, DCIS is for the breast conservation. But if there is a contraindication for radiotherapy for DCIS also, then we have to choose for the mastectomy. That is simple mastectomy without any axillary dissection. In that case, we should go for the sentinel lymph node biopsy also, so that we can confirm that there is no invasive component metastasized to the axillary nodes. Because if we have done the mastectomy, we cannot do sentinel lymph node biopsy later on. If there is any suspicious features in DCIS, including large DCIS area radiologically or a palpable DCIS mass, then also we should go for the sentinel lymph node biopsy, taking it or assuming it as a invasive malignancy. Because it has been seen many times, as I have reported 10 to 20% incidence of the invasive component also proved in DCIS diagnosed cases when we have come with the final histopathology report after surgery. What are the contraindications for this? When we should not go for the breast sentinel lymph node biopsy. All T4 lesions, no sentinel lymph node biopsy. They are always aggressive malignancies. Axillary dissection should be done. T3 lesions are in between. They have relative contraindications, as discussed. As if the T3 lesion is there in the big breast, we still can do for the breast conservations after neoadjuvant. But T3 is subjective to the patient surgeons also. T3 can go for the breast conservation and can go for the complete modified radical mastectomy. All T4 lesions, pregnant females, because they should not be in the they cannot go for the radiation exposure. And previous cosmetic breast surgeries, we cannot do sentinel lymph node biopsy because lymphatics have been altered in that cases, or any excisional biopsy has been done already, then also we cannot do sentinel lymph node biopsy, because first sentinel lymph node biopsy we have to inject dye peritumoral region. And anybody want to speak?
You can continue, sir.
Okay. So if we have done any excisional biopsy and no lump is there, we cannot do sentinel lymph node biopsy in that case. So they are the contraindication for sentinel lymph node biopsy. Now we have done the sentinel lymph node biopsy. What now? If the sentinel lymph node biopsy has come as positive, do we need to do axillary dissection in all cases? No, there are few very selective cases where even we have found the sentinel lymph node biopsy is positive. Still, in some cases, we can avoid axillary dissection. These are the points where if all the 5 points are present in a single patient, in that case, we can avoid axillary treatment even if the sentinel lymph nodes are positive. Number one is the clinically negative node. We cannot palpate any lymph node clinically before surgery, including imaging. There is no radiological lymph nodes visible, either in the USG or the PET CT. And there is a T1 or T2 lesion. Patient has undergone for breast conservative surgery, and he is definitely going for the whole breast irradiation, which includes the axilla as well. And there is only 1 or 2 lymph nodes are positive in sentinel lymph node biopsy. Fewer than 3, it means 1 or 2. If more than that, we have to definitely go for the exit dissection. If 1 or 2 metastatic lymph nodes there, but it is a very small tumor, clinically it was negative axilla, and patient are going to take whole breast radiation in axilla also, and there is no previous chemotherapy was given as a new adjuvant therapy. In all, if all the criteria are present, then we can avoid axial dissection in limited sentinel lymph node biopsy positive cases as well. But rest of the cases, if the lymph node biopsy is positive, then we have to go for the full conventional axial node dissections, level 1, level 2. 3 or more metastatic nodes, or 1 or 2 metastatic with other negative factors, or who do not desire for the radiation. In that case, we have definitely to go for axial dissection. Now we have done the mastectomy, we have done the breast conservation or axial management. After surgery, what we need to do in early breast cancer cases? If we have done the breast conservation, radiotherapy is mandatory in all cases. That is the local control for the residual breast, whichever we have left. It should be radiated for any DCIOs or any microscopic disease remaining there, should be managed with radiotherapy. And for the systemic treatment, lymph nodes are negative. It is very small tumor. We can avoid systemic treatment in very small tumors, like less than 1 centimeter. We should be avoided. But if any specific indications is there, systemic management is through the chemotherapy or through the hormone therapy. So when we should go for the radiotherapy? All breast conservative surgery, as I have discussed before also, breast conservation surgeries definitely need radiotherapy. Any positive lymph nodes, either it is central lymph node or either after the exit dissections, positive lymph nodes, even single lymph nodes, it means radiotherapy is mandatory. All close margins, which is 1 mm, 1 mm is called close margin, they need the radiotherapy. Any tumor size of more than 4 to 5 centimeter, it is the indication for radiotherapy. Or any tumor which is 2 centimeter, but there are other risk factor in the biopsy, that is the lymphovascular invasion or the triple negative status, ER/PR negative, HER2 negative. They have a very young stage. They have a history of family history of breast cancer, hereditary cancers. In such all high risk factors are indication for the radiotherapy as additional. Except this, it's a very old age patients with the life expectancy is not very high. It's 80, 85 years old patients. We can avoid radiotherapy. Pregnant females or the non-availability of radiotherapy systems, we can avoid radiotherapy. There is a specific, very selective patients to be considered for a different irradiation pattern, that is accelerated partial breast irradiation. This is to be considered in very specific patients. In that case, when we want to finish the radiotherapy, not for the whole month, but in the 10 fractions only, we have to give the radiotherapy in the morning, evening, 2 sittings, only in 10 fractions, so that patient compliance will be better, and radiotherapy can be finished earlier with less side effect, with a comparable result to the whole breast radiation. In that case, what are the selection criteria when we proceed for the patient, or when we motivate the patient for the partial breast irradiations? That the patient should be more than 50 years. As we have discussed in the previous slides, that very old patients should be avoided with the radiotherapy. So if the patient is more than 50 years, with the BRCA mutation negative, means they don't have any component of family hereditary breast cancer or not very high risk breast cancers. They have had a very small tumor, that pre-treatment stage was T1 and 0, no X-ray nodes, only 2 centimeter, maximum 2 centimeter tumor, or all margins were negative, and there is no lobular component in situ. In that cases, we can give the accelerated partial breast irradiations, where the tumor bed with the tumor bed is irradiated, not the whole breast, with small fractions and for small duration. When to give the adjuvant chemotherapy in early breast cancer? All triple negative cases definitely is an indication for chemotherapy. All tumor of more than 1 centimeter, or even a single positive lymph node, is an indication for chemotherapy, because the invasion of a single positive lymph node shows that the cancer cells have been started to spread into the system. So if the tumor has gone into the system, the systemic treatment is mandatory. So adjuvant chemotherapy for even a single positive node or more than 1 centimeter should be given. But it has to be individualized on person to person basis. Patient should be quite fit enough for the adjuvant chemotherapy. They should have a good life expectancy further. because favorable histology without any lymph nodes, and if they are ER/PR positive, hormone positive, in such specific patients in the advanced age, they can be kept on the adjuvant hormone therapy, that is tamoxifen. Because some patients in the old age cannot tolerate chemotherapy, and they have a risk benefit ratio, they have more risk than the benefit with the chemotherapy. And overall, what have been seen that only additional advantage of chemotherapy in early breast cancer is only 5 to 10%. So if the patients are not fit or not so aggressive tumor biology, in that case we can avoid the adjuvant chemotherapy. Mandatory thing is that patient should be hormone positive, so that they can be kept on at least some follow-up risk reduction therapies. So role of neoadjuvant therapy in early breast cancer. As in the starting we have seen a very small tumor, we should directly go for the surgical management. But simultaneously we have seen that our target of the therapy or target of the treatment is not only just the tumor cure, but we want to preserve the breast, and we want to keep the psychological issue also in mind, so that even in the last tumors we prefer to go for the neoadjuvant therapy to reduce the downstage the breast tumor size. So the neoadjuvant therapy is not required in the stage 1, very small tumor, we can remove surgically directly, or the patient who fill all the criteria for the breast conservation surgery except size, means patient want breast conservation, and they have fulfilling all criteria, they don't have any contraindication for radiotherapy, except that they have a big size uh, for the breast conservation. In that case, neoadjuvant chemotherapy definitely have a role. By the neoadjuvant, we will decrease the size and go for the breast conservation. And this is the only main indication for the neoadjuvant chemotherapy in early breast cancer. They are the few examples of the neoadjuvant hormone therapy also. There's a written, the neoadjuvant hormone therapy has promising result in the patient which are not fit for the chemotherapy. We can kept on the hormone therapy in hormone positive patients to downstage the tumor, and that have also shown a very good results in many cases. And this is an example of our case. It was a huge tumor which are involving the skin also. We have just kept on the neoadjuvant hormone therapy. It was not chemotherapy, hormone therapy, and it was downstaged to a significant size before surgery. You can see in the pictures, the huge tumor with the skin involvement, it reduced to a significant size. And even in the, it is a locally advanced cancer, it is not the early breast cancer. In a locally advanced cancer also, there are the emerging role of breast conservations after neoadjuvant therapy. So why we are emphasizing the breast conservation surgeries in compared to modified radical mastectomy, and what are the specific features what we need to counsel with the patient, what we should keep in the mind for the breast conservation surgeries. That breast conservation surgeries, we have to explain the patient that radiotherapy will required in all cases. Even in a very small tumor, if we are going for breast conservation, we have to give radiotherapy to the residual remaining breast. And the breast conservation surgery is not, those patients are not very high risk, on very high risk for the recurrence. They are only 5 to 10% additional recurrence rate in comparison to modified radical mastectomy if we have taken the radiotherapy also. Because we are tackling with the rest of the breast with the radiation, and patient has a psychological issue after removing the whole breast. Even in the big breast females, they have the center of gravity issues also, they have the balancing issues also in the body, they can have the shoulder pain on one side also. So in that cases, always the breast conservation helps in other issues also, with additional risk of 5%. Additionally, the PCS has a satisfactory cosmetic results with a very less morbidity in respect to the mental stress, social disgracefulness, and the quality of life. That's the main purpose of giving the breast conservation. There is no need of any prosthesis also for the normal appearance, and the small oncoplastic surgeries can help in the maintaining the breast contours even after a large tumor removal to fill the cavity. These are the another examples of the breast conservation surgeries. We can see this is the scar of the axillary dissection. Sorry, this is the scar for axillary dissections with a tumor removal here in the breast. See, this was in the sitting positions, showing the nipple and everything on the same level with the same contour compared to the another normal breast, and it is in the lying down positions. We hardly find this axillary scar only for removal of the upper outer quadrant tumors. We can do it with the same incision also. This is another case in the lying down position. We can see a scar here, which we have removed the tumor in the lower quadrant. And when we see in the sitting positions, there is no sign visible of any surgery in the after breast conservation. If the defect in the breast conservation is too big to maintain the contour of the breast, we can go for the reconstructions in the conservation also. Here we have taken the latissimus dorsi flap from back, and through this tunnel, we have taken the latissimus dorsi here to give a bulk in the cavity, which is formed by the removal of that lumpectomy part. And this was after the complete wound recovery. See, there is no significant change in this breast in compared to her normal breast. So the breast conservation is a very viable, very useful options for as a standard management of the breast cancers nowadays. This is another tumor in the another example of the locally advanced breast cancers where we have done the breast conservation. Here is we have also taken the LD muscle flap with the skin, and we have reconstruct the part of the skin which is removed in the ulcerated skin. So it gives a cosmetic appeal, not at least we have preserved the nipples also, we preserve the normal sensation also. So it gives a very psychological relief to the patient. We don't prefer the prosthesis in such cases because the prosthesis doesn't give any sensations to the breast. It gives the shape of the breast, but it doesn't give the normal sensations, normal nipple stimulations. So psychological issues come generate from here also. They have long-term complications. They with the long-term follow-up, we have seen that they changes their shape, they disintegrate. They're difficult to follow up also. We cannot do the ultrasonography or mammogram in the follow-up with the prosthesis. They always need the MRI, which may not be affordable to all patients. Even for the prosthesis with silicone breast, we need to repeat the process after some years. And local recurrence may be hidden. The small local recurrences which cannot be palpated in the prosthetic breast. So they can be hidden inside or in behind the prosthesis. So the message of this lecture is that the era of the mutilating surgery for the breast has gone. We should always try, we should develop the screening programs for the early detection of the breast. The professor introduced me with the screening. Sorry, I have not talked about the screening in this presentation because screening will be a separate issue and separate discussion, but the early detection should be started. As in the Uganda, when I was there, we have done a lot of screening programs in that year. So early detection and screening programs should be done every year in all countries, all populations, so that we can start the early detection of the breast cancers, which gives breast conservation opportunities to the patients and better survival also. And then we should follow the protocols what we have discussed for the early cancers, and then regular follow-up, so that we can move on for the breast conservation. Thank you everyone for the patience of hearing. If anyone want to ask any questions, any doubts.
Thank you very much, Mr. Deacon, for this very nice and precise presentation. Welcome, Professor Rashid, and all the participants. Now it is time for discussion.
Hello, sir.
Hello.
Thank you very much for the wonderful presentation. And actually, I'm not sure if this has been mentioned in the earlier slides. I catch you late. But my question is, if what's your approach or policies if you have a patient of palpable lymph nodes suspicious and prove to be a malignant lymph nodes by fine needle aspiration and the breast is normal? What will you do?
Breast is normal. You are saying the breast is normal, huh?
I mean, no palpable masses in the breast.
We have to see the mammography also, because sometimes in the very early breast cancers can also give the lymph nodes.
Lymph nodes are suspicious. You took and find it, and it proves that it's
that's
a
what I'm saying. Very
case.
early breast cancers, which are not palpable, can also give lymph node transmission. In that case, we have to detect the primary lesion also. We should go for the mammography. Sometimes the non-palpable mass can be visible in the mammography as a clustered microcalcification. If any lesion picked up in the mammography, we can take that mammographic part. In the mammographic guidance, localization of that area can be done, and that has to be tackled as a breast conservation with the axillary lymph node dissections. Or even if the mammography doesn't pick any mass or any breast changes, then we should opt for the MRI. MRI is ideal in such cases for the non-palpable breast lesions.
Dr. Wala, you are welcome. Professor Rashid, you are welcome.
Yes, yes. Thank you, Jain. Can I ask?
Yeah.
Yeah. I would like to just to know in your practice, what is the ratio between those presenting with early breast cancer to those with advanced? I mean, how much you do breast conservation surgery in percentage compared to the advanced malignancy? And the other question is that what will you do when you have a new adjuvant with complete clinical mammographic disappearance of the breast mass?
So, if the in our practice, most of our burden of the breast cancers, we are dealing with the breast conservations. It's very rare nowadays when we are doing the full modified radical mastectomies, because they are the screening programs, very routine screening programs, and their awareness depends on the patient awareness. And people are coming with the screening mammography each year. So we are detecting even non-palpable lumps also, which is shown in the mammography only. So we have done a lot of cases in the breast conservation for the early breast cancers. Even the breast conservations can be done in the locally advanced cancers also, depending after the neoadjuvant response. And for the second questions, if after the neoadjuvant therapy, if the breast lump has completely disappeared, actually the staging doesn't change with the neoadjuvant therapy. We have to manage the cancer patient on based of the previous pre-treatment in imaging. If there is a mammographic lump before neoadjuvant chemotherapy, we have to localize that mammography lump based on that previous mammography, and we have to remove that part of the breast in the totally disappeared lump. Even if we have any doubt that we have removed completely or not, in that case we have to go for the complete breast modified radical mastectomy. But it's always advisable when we go for the neoadjuvant chemotherapy, we should localize. Ideally, we should localize that lump before starting any therapy. That can be done with the clipping. Some radiologically directed clips are there. We can put that clips under mammographic guidance or the radiological guidance, and then we should start the neoadjuvant therapy, so that even after the treatment, if the lump has totally disappeared, we can remove according to that clips guidance or radiological markers guidance.
Sometimes we need to modify the treatment according to the local culture. I mean, you have some patients who don't like their breast to be removed anyway, and other patients, they don't like to go to the radiotherapy because of the stigma. So sometimes you find that, I mean, the understanding of the patient, how can you follow a patient even from a very far place? Probably you might to see the patient really local, probably understanding of the disease.
Yeah. We have to individualize the treatment according to the patient demands, actually.
Anyone have any question? So, please unmute yourself and ask the question if anyone have any.
Hello, sir. My question is about, you said that if there is positive lymph node after axillary dissection, this is an indication for radiotherapy. Some people, they don't use the two modality for axillary management, combination between radiotherapy and surgery. They just use one of them.
I'm not hearing properly.
Is that the practice?
Hello.
Hello.
Please can you repeat your question, Yusuf?
Okay, sir, you said that if there is positive lymph node after axillary dissection, this is an indication for radiotherapy.
Yes.
I think some people say that after axillary clearance, you don't need to radiate
I made to clear that point. When there is a positive lymph node, we have done the complete axillary dissections, but the indication for radiotherapy is not for the axilla. We have to give the radiotherapy to the breast, because the presence of the lymph node shows the advanced stage. I doesn't mean that we have to give radiotherapy to the axilla. It means the radiotherapy has to be given to the breast, not to the axilla. After axillary clearance, we don't need to give radiotherapy to axilla. It is only for the breast.
In the same line, how frequent do you get lymphedema following modified radical monostotic?
It's not very common, but it's common. I have seen many cases with the lymphedema, but it's not in all cases. Actually, there are some points during the surgery when we keep the axillary dissections below the axillary veins, when we avoid level 3 axillary lymph nodes. There are some things, some maneuver we can avoid to prevent the lymphedema in most of the cases. Just we should never go about the axillary veins, never go to a level 3 lymph node dissections until the level 2 has a big lymph node. That's what we can do to avoid the lymphedema.
Dr. Amin, do you have any question?
Yes, thank you for this nice lecture. I am asking about the breast conservative surgery during pregnancy. I know that in the first trimester is absolute contraindicated, but what about the third trimester? I need you to clarify when to give the radiotherapy and to either to give chemotherapy.
Yeah, when the patient, it totally depends on the trimester of the pregnancy, because if the patient is pregnant, we cannot give for the radiotherapy. In that case, either it depends on the patient preference also. Either they have to choose whether they want to continue the pregnancy. If the patient has been diagnosed in the first trimester of the pregnancy, and the whole treatment like the chemotherapy and the radiotherapy, they all go against the pregnancy. In that case, it is always advisable to prefer the patient's life rather than the child. And if the patient accepts, then the pregnancy should be discontinued. Or if the patient has been diagnosed in second, third trimester, then we can go for the surgery first in that cases, and let them complete the pregnancy, and then after some delay, they can give the radiotherapy. They can take the radiotherapy. But the first trimester, they should always discontinue the pregnancy.
Sir, is there any difference between management of young or elderly ladies presented with early breast cancer?
Management is same in the both, except that in the very young patients, we have to think about the genetic screening also. We have to go for the BRCA mutations, and family history is also important. But the actual management plan doesn't change. Management depends on the stage, not on the age of the patient. Early breast cancers are little aggressive, more for the triple negative status. In that case, we have to manage them aggressively. But the standard of the protocols doesn't change for the early, young patients or the old patients, except that in very old age, as I've discussed in the slides also, that they can be kept on the hormone therapy, or rather than giving the toxic chemotherapies, and radiation also can be avoided considering how much is their life expectancy. While in the young patients, we have to give all three combined modalities, considering the stage of the patient.
Dr. Murtada, you have any question? If no more questions, thank you very much, Dr. VIKAS for this very nice presentation, and we hope to see you next meeting soon in the future. Thank you, Professor Rashid.
Sure.
Thank you all of our participants, and we hope to see all of you at 7 p.m. in the next lecture about breast reconstruction as continuation of this series of breast cancer. Thank you.
Thank you very much.